So we'll talk about glaucoma here. Obviously, this is very important for the USMLE, but also, more importantly, very important for real life, especially if you work internal medicine, family practice, emergency medicine, of course, ophthalmology, but this is not going to be a big enough review if you're an ophthalmology resident. But if you work with an older patient population, you should be particularly wary of this because as the US population begins to age, as it is now, this is going to be more and more important. Okay, so we'll talk about some anatomy to orient ourselves, get some key processes down, epidemiology. Mostly I want you to be aware of the patient populations that are at particular risk. Some terminology, and that's just so going forward you have you can be able to compare and contrast these things. And we'll talk about the two major families of glaucoma, to put it informally, angle closure glaucoma and open angle glaucoma. If you look at these, one of these disease processes stands out, acute angle closure glaucoma. If you've been watching these ophthalmology videos, you probably know that this is an emergent process, whereas chronic angle closure glaucoma and primary open angle glaucoma are more chronic processes. So chronic angle closure glaucoma and primary open angle glaucoma share a lot more in common clinically than chronic angle closure glaucoma and acute angle closure glaucoma do. So these are divided up as far as their mechanism, but clinically they're much different. Okay, and then after that we'll talk about two other Glaucomatous-like processes that I want you to be aware of, particularly for real life, but they may come up on the USMLE, and then we'll do a quick review. Okay, so here's looking at our eye, and the anterior portion of the eye is where the disease process is going to start. So you have the ciliary body, the posterior chamber, the iris, pupil, anterior chamber, lens, and then ultimately, you can't see it here, but that's maybe what these little circles are representing. But you have your trabecular meshwork and Schlemm's canal, where we drain the aqueous. Of course, the posterior part of the eye, the retina, and the optic nerve head are going to be important as well, but that's where the disease actually will cause its effects. So you have elevated pressure in the anterior portion, the aqueous chambers, and that's going to compress the retina, and as the retina is compressed, you have compression on the nerves and on the vasculature, on the optic nerve head, and that's going to lead to your disease process. So as far as looking at the back of the eye, of course that is important, especially when it comes to making a diagnosis. Okay, so this is looking at from the top. So this diagram shows you approximately where we're looking. This diagram is looking from the lateral side. Here we're looking from the top of the eye. So if you're looking downward from the top of the eye. Here's your ciliary muscle here. There's an important part of the ciliary muscle called the pars placata. I'm not sure if this arrow is perfectly situated on it. But anyhow, the pars placata is the non-pigmented portion of the ciliary muscle, and it produces aqueous humor. And the aqueous humor will flow from the posterior chamber to the anterior chamber, and then ideally into the trabecular meshwork, where it's then drained. So aqueous humor goes around the iris here, and remember that the iris can take multiple different configurations. It doesn't always look like this. Of course, this is a histologic slide, so this is probably not an anatomic position. But anyhow, the aqueous humor will go around the iris no matter what, and then ultimately drain into the anterior angle and the trabecular meshwork. So this is the anterior angle. When we talk about the angle here, this is what we're talking about. We're talking about the angle that's formed by the anterior iris, the trabecular meshwork, and the cornea. So here's the trabecular meshwork here, just kind of zoomed in. So what we're really zoomed in here is this little portion right here. And the trabecular meshwork is just a mass of tissue that has these little fenestrations in it, Ultimately, it drains into Schlem's canal, which will then drain into a vein. And that's how you drain out your aqueous. All right. So the epidemiology is pretty vast. 100 million people worldwide suffer from glaucoma, of whom 2.3 million are in the U.S. We have a slightly smaller share proportionally to the rest of the world, mostly because of our demographics, because Asians are at higher risk for glaucoma. So the bulk of the glaucoma patients are in Asia. This is the second leading cause of blindness in the world. What is the number one cause of blindness in the world? It is cataracts. So this is a very significant cause of blindness in the world, along with age-related macular degeneration and some other processes. Okay, so the risk is higher, of course, in older patients. The older you get, the more likely you are to develop glaucoma. It is higher in blacks, 3 to 4 times the risk compared to the rest of the population. And then also high in Asians. Asians are at particular risk for the chronic angle closure glaucoma, which we don't see as commonly in the U.S. Because we don't have a very high Asian population. But if you were to go to Asia, this would be one of your leading glaucoma causes. Of course, patients with a family history of glaucoma, most diseases, if there's a family history, tends to correlate, but most glaucoma genes are autosomal dominant with variable penetration. There are some that are autosomal recessive, particularly the steroid-sensitive glaucomas. And then patients who are myopes and hyperopes mostly would fall under that chronic angle closure glaucoma, just like Asians. Patients with thin corneas, and then patients taking steroids. Okay, so some terminology. So the angle closure glaucoma is glaucomatous symptoms, ultimately developing in a patient with elevated intraocular pressure and a narrow or closed angle. So this is the problem here. This angle is for some reason not able to drain. It's closed. Okay. So this can be one of two processes, and they're very different. Acute angle closure glaucoma is an emergency, and you can't miss this because this is a patient who has red eye, severe pain, probably the worst eye pain they've ever had in their life. They've got a steamy cornea. They've got basically no vision, just light and maybe hand motions. And this comes on suddenly. So this is much different from the rest of these processes, which are more insidious. In these patients, they'll have a high intraocular pressure, usually in the 40s, 50s, and 60s and beyond. And remember, the normal intraocular pressure is 12 to 20 millimeters of mercury, so a very high intraocular pressure. And this is a vision-threatening and ophthalmologic emergency. So this is a much different process than the rest of these, even though pathophysiologically it is due to an angle closure. Chronic angle closure glaucoma is where you ultimately develop glaucomatous symptoms, ultimately due to a high intraocular pressure, but this is more insidious onset, and it's seen particularly in hyperopes and in Asians. Hyperopes, because they have smaller eyes, so they tend to have smaller chambers, and so because they have smaller anterior chambers, the angle tends to be smaller. Open angle glaucoma is essentially where it's a glaucoma process where the angle is not closed. So it's really a diagnosis of exclusion. And so this is where you will ultimately develop glaucomatous symptoms in a patient who has elevated intraocular pressure but a properly opened angle. Now, as we're going to see when we talk about open angle glaucoma, not all patients at diagnosis have an elevated intraocular pressure. They do have abnormalities of their cup-disc ratio, but it's a little bit more complicated than this. Like I said, primary open angle glaucoma is a diagnosis of exclusion. So this is often, but not always, due to abnormally structured trabecular meshwork. There's normal tension glaucoma. Now that sounds like a contradiction. I thought glaucoma was from elevated intraocular pressure. Well, it usually is, but not always. So in normal tension glaucoma, you have glaucomatous symptoms that develop in a patient who always has normal intraocular pressure, and they always have a properly opened angle. So you would think that they wouldn't develop glaucoma, but they do. And this tends to be associated with vasospasm. So we'll talk more about this, but this has a correlation with other things that are associated with vasospasm, like migraines. And then ocular hypertension is sort of the opposite of normal tension glaucoma. And these patients who have an elevated intraocular pressure, but the patient doesn't have any symptoms of glaucoma and they don't have any optic disc abnormalities. So it's just a normal patient who is just walking down the street, no problems, nothing going to happen, and they've got elevated intraocular pressure for one reason or another. It's just isolated elevated intraocular pressure. Some of the procedures that are done, certainly not all the procedures that are done, but some ones that you may not have heard of. Tonometry, this is a measurement of the intraocular pressure. The normal intraocular pressure is 12 to 20 millimeters of mercury. Pachymetry, this comes from the Greek word pachy, and pachy means dense. So like when you're talking about the pachyderms, like elephants and rhinoceroses, those are thick skins. So pachymetry is a procedure that's performed to measure the thickness of the cornea. And remember, a thin cornea puts you at risk for glaucoma. And then gonioscopy is another important intervention that's done, and this is a procedure that's performed to measure the anterior chamber angle. This is done by an ophthalmologist. This requires training, so you're not going to do it, but you should know that gonioscopy is a procedure that's done to measure the anterior chamber angle. So in real life, just as a sort of preface to all the stuff we're going to talk about, anytime you suspect a patient has glaucoma, immediately you should consult ophthalmology, because they're going to be the ones that will make the official diagnosis. They're going to direct and they're going to choose the treatment. Making the diagnosis of glaucoma requires a diagnostic battery, and a lot of those diagnostic tests are specialized tests that it requires an ophthalmologist or an optometrist to perform. The only big exception is if you suspect that a patient has acute angle closure glaucoma, if you're working down in the ED. So this obviously is an emergency. If it's 3 o'clock in the morning, you're not going to wait until 4 o'clock or 5 o'clock for the ophthalmologist to get there. You're going to treat them right away. So if you suspect angle closure glaucoma, you'll treat them right away. You will consult ophthalmology nonetheless, but you're going to treat them right away. Okay, so acute angle closure glaucoma. This is a sudden glaucomatous exacerbation, either in a patient who has glaucoma or who doesn't, always due to an insufficient anterior angle. And this causes a sudden elevation of the intraocular pressure due to decreased drainage because of the small angle. The causes of this can be intrinsic or extrinsic, but typically they're a little bit of both. So intrinsically, about 1% of all people, particularly Asians and hyperopes like me, have, in case you didn't know, hyperopia just means farsightedness. But 1% of all people have anatomically narrow anterior angles. So that's a fact. Extrinsically, so other things that can cause this that you're not born with, anything that dilates the pupil can result in an attack of acute angle closure glaucoma. And the reason for this has to do with the tautness of the iris and the trabecular meshwork and the ciliary body, and it's a very complex, involved anatomic, pathophysiologic process. So I don't want to stress it too much here, but anything that dilates the pupil can result in an attack of acute angle closure glaucoma. So that is something worth remembering. And so things that can cause this: being in a dim lit room, stress. Why? That activates your sympathetic nervous system. Sympathetic nervous system will inhibit your sphincter pupillae muscle. Anticholinergics, pretty much the same reason, works against acetylcholine. So that would be like the drugs that they give you to dilate your eye, to do an eye exam. SSRIs, phenothiazines, that would be like your anti-nausea drugs. and then sympathomimetics. Another one here, as far as anticholinergics, an important one, especially because they're so widely used now compared to in the last 10 years, would be those drugs like Myrbetriq that are used for overactive bladder syndrome. Okay, so here's acute angle closure glaucoma. Essentially what's happening here is when the pupil dilates, the iris relaxes, and when the iris relaxes, it becomes more convex. And when it becomes more convex, it can interfere with this angle. Okay, so the pupil dilating is usually what will elicit the problem here. So anything that causes the pupil to dilate can cause an attack of this. So on presentation, the patient will typically present, they will always present with severe ocular pain. That's a key feature of this, eye pain, and also very blurred vision. So the red eye with acute angle closure glaucoma is a secondary finding. Of course, acute angle closure glaucoma is a differential of red eye, but when the patient comes in with acute angle closure glaucoma, they're not going to come in and say, "Doc, my eye is red." They're going to come in and say, "My eye is so painful, I'm throwing up, I feel sick, and I cannot see out of it." So usually when you look at the patient's eye, of course it will be red, but they tend to also have a mid-dilated pupil. They may have a hazy or steamy-looking cornea, and that's just due to the elevated intraocular pressure, and it tends to respond sluggishly. Of course, the patient can also have nausea and vomiting as well, usually just due to the pain itself. Classically, the eye is rock hard. So if you feel your own eye, just gently press on your own eye or a patient's eye, you'll notice that there's a little bit of give to it. That it's not mushy, but there's a little bit of give to it. It's not hard. When you feel the patient with acute angle closure glaucoma, the eye is very, very hard, especially if you compare it to the other eye. That's a good way to determine whether the patient's eye is hard or not. Compare it to the other eye. If it feels a little harder, then there's probably something wrong. For diagnosis, the best step is going to be tonometry. So with this clinical finding, this clinical presentation, if you do tonometry, which is a pretty easy test to do if you have the device, and you find an elevated intraocular pressure, then that pretty much confirms the diagnosis. So the clinical presentation, usually that's almost enough to diagnose acute angle closure glaucoma, but you should do tonometry. Tonometry will then confirm the diagnosis. A lot of times the patient's intraocular pressure is not only elevated, but severely elevated, more than 50 millimeters of mercury. But any elevated intraocular pressure will confirm your diagnosis. The management, you need to be aware of this for the USMLE. This will get you a point on your test, I almost guarantee you. So the very first step is IV acetazolamide. Why don't we do something topically? We don't do anything topically typically because with acute angle closure glaucoma, by the time it's set in, there's usually too much vascular damage for something topical to help immediately. So we give acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor, and this pulls in aqueous faster into the veins. And by doing that, you drain the chambers. If this does not help, then there are second-line agents that you can use, like osmotic diuretics, urea, and so forth. Of course, you'll want to call ophthalmology emergently. They need to be consulted in this. And then you'll get serial tonometry. Usually these patients are admitted. You'll get serial tonometry. Once the intraocular pressure begins to drop, then you will administer topical pilocarpine. And pilocarpine is a miotic agent, and this will open the angle up. And then, of course, you'll want to manage, usually ophthalmology will do this, but you'll manage any other predisposing ophthalmologic condition. Okay, so this is a completely different animal here, chronic angle closure glaucoma. This is not very common in the US, but it's more common in Asia. This is a chronic glaucoma that's often caused by things that can narrow the angle. So this would be things like synechia, and that's just adhesions of the iris to the lens, a lot of times caused by uveitis. A narrowed anterior angle, like just an anatomic narrow angle, so particularly in Asians. And the elderly, the iris changes, the lens changes, and both of those processes tend to narrow the angles. Patients with cataracts, their angle will narrow as well. Patients with physiologic lens thickening, so the elderly, their angle will narrow as well. So chronic angle closure glaucoma. Presentationally, it's nothing like acute angle closure glaucoma. That should say AACG. Acute angle closure glaucoma. Patients are typically asymptomatic until much later in the course, usually, unfortunately, when they start to develop symptoms. So the symptoms, when the patient becomes symptomatic, they will develop mild blurring, visual field deficits, usually paracentrally along the horizontal midline, halos, redness, and iris blotches. These iris blotches, these little pigmented spots on the iris, are a key feature. For diagnosis, gonioscopy is going to be what's going to help you differentiate chronic angle closure glaucoma from open angle glaucoma. So when we look at open angle glaucoma, you'll see why gonioscopy is so important. You're going to do your entire diagnostic battery, or the ophthalmologist will, where you're looking at the visual fields. You're doing a slit lamp, you're doing gonioscopy, you're doing tonometry, etc., pachymetry. But it's the gonioscopy that tells you have a narrow angle that's going to help you distinguish this from open angle glaucoma, which, of course, as I've mentioned, is a diagnosis of exclusion. So the gonioscopy will show you that indeed you have a narrow angle, and in the setting of a patient with glaucomatous symptoms or glaucomatous features, that will indicate that this is a chronic angle closure glaucoma. So the management for this is going to be to refer the patient to ophthalmology. The ophthalmologist will perform an iridotomy, which is where they, well, I'm not say drill, but they burn a little hole in the iris, and that iris then can drain better. And then anti-glaucoma medications are typically then needed after surgery. Primary open angle glaucoma. I want to talk about this one the most because this is the most common one in the U.S. So this is the most common form of glaucoma in the U.S. and along with normal tension glaucoma makes up 90% of all glaucoma cases in this country. This can present with symptoms, but more commonly it's detected on routine eye exam due to optic disc abnormalities. Even if it's silent, which it typically is, the patient will inevitably go on to develop symptoms. So this is really the problem, screening and finding open angle glaucoma before it goes on to develop symptoms. It's recommended that a patient see an optometrist every 2, 3, 4 years to get an optic disc exam and for other reasons. But the best way to screen for glaucoma is to look at the optic disc. Symptoms, by the time they happen, it's usually too late. So the characteristics are optic disc abnormalities. Just in the setting of optic disc abnormalities, just by that, you can really narrow your differential down to glaucoma. And so what are we looking for in the optic disc? We're looking for an increased diameter of the optic disc or an elevated cup-to-disc ratio. Now, the normal cup-to-disc ratio is 0.3 or less. But with primary open-angle glaucoma, and really a lot of the other glaucomas too, like chronic glaucomas, the cup-to-disc ratio is going to be more than 0.5. And then, of course, it's important also that the patient has a normal open anterior angle. So gonioscopy is going to be one of the things that you're going to do, or the ophthalmologist is going to do, in making this diagnosis of exclusion, primary open angle glaucoma. Because if the patient had all these findings, but they also had a closed angle, then your diagnosis would shift to chronic angle closure glaucoma, and your treatment would be different. So there may or may not be elevated intraocular pressure at the initial diagnosis. This is important. So the USMLE will probably throw it at you, a patient with optic disc abnormalities. It looks just like a glaucoma patient, but their intraocular pressure is normal. That can happen. So a patient with primary open-angle glaucoma can have the glaucomatous changes. They might not even have visual symptoms. They just have optic disc symptoms, and they don't even have elevated intraocular pressure at the initial diagnosis. If they're not treated, however, they will eventually go on to develop elevated intraocular pressure, and they will go on to develop symptoms. Okay, so it is perfectly possible for a patient with primary open-angle glaucoma to present solely with optic disc abnormalities, and this is exactly the dilemma that causes us to not be diagnosed until it's too late. And by too late, I mean irreversible visual damage. So here is a normal optic disc. So we're kind of zoomed in here on the optic disc. You can see all these little nerve fibers kind of coming in, arteries, a little bit of copper wiring going on here. This patient might have a little bit of diabetes, but this is a normal optic disc. And so here is the cup, and here is the disc. So when you do the cup to disc ratio, the cup is roughly 0.35, maybe 0.3, but this is normal. This is a normal optic disc. Okay, so this is an optic disc in glaucoma. So you can see the disc here and the cup. So this is 0.75, obviously much greater than 0.3, 0.5. 0.5 is most of the time, technically an elevated cup disc ratio is more than 0.3, but in glaucoma you're usually going to see a cup disc ratio of more than 0.5. So this would be a severely elevated cup disc ratio, 0.75. But ultimately it can develop to the point where the patient will have almost no visible disc. The cup will take up the whole thing. So here's another one. And another. So when symptoms present, the patient is typically later on in the course of the disease. Symptoms will usually involve visual field deficits, classically paracentral or arcuate. They'll have halos, rainbow halos. What that means is just if you kind of I don't know if you've ever gotten water in your eyes and you've looked at light and you kind of see the little rainbow halos around it. It's kind of what it's like. Mild eye pain and redness. Patients suspected for open-angle glaucoma, certainly as mentioned, should be referred to ophthalmology, and several tests are necessary in diagnosing primary open-angle glaucoma because it is a diagnosis of exclusion. So fundoscopy, of course, to look for optic disc changes. Usually that's done before you refer. Gonioscopy to rule out chronic angle closure glaucoma. Serial tonometry. Why is that important? Because you want to rule out normal tension glaucoma. Slit lamp examination and visual field analysis. So this would be an example of a glaucomatous visual field deficit. So we talked about visual field deficits in the neurology section where you might have a homonymous hemianopsia. That would be a visual field deficit that's usually taking place in your brain. A glaucomatous visual field deficit doesn't look anything like those hemianopsias or those quadrantanopsias or bitemporal hemianopsia or those things. The glaucomatous visual field deficits reflect that there is a problem on the retina, and so that's going to be a lot different. So here's an example. This would be an arcuate defect. This would be a early paracentral defect. These are examples of visual field deficits you would see solely in glaucoma. And so, let's see here. Okay, so why does that happen? So you have bundles in your retina of nerve fibers that are coming in to leave as the optic nerve. And these bundles are, we'll name two bundles. You've got this right here, which is called the macular bundle. So this comes from the macula I think it's called the papillomacular bundle. But this is the first bundle right here. So this is kind of surrounds from the like fovea area around to the disc. Then you have these other bundles here. You can kind of see that they follow a different path. So rather than going to the fovea, they go outwards. And these are your arcuate bundles. And these tend to be the first bundles that are damaged in glaucoma. And then you have these bundles out here, nasally. So these bundles here, these arcuate bundles, extend from the optic nerve head to the temporal side. So as a result of that, if, for instance, you damage an arcuate nerve bundle, you're going to lose vision nasally. So it's going to be from the middle, roughly around the middle of your visual field, and then nasally from there, because this is how the image projects on the lens. And if you have an arcuate defect that affects the superior arcuate bundle, then it's going to be in the inferior visual field and vice versa. Okay, so this would be how your classic arcuate defect would be. But all of these are glaucomatous deficits. So they don't look anything like those classic visual field deficits that you see, like, for instance, if you had a tumor in the brain. It's not hemianopsias or quadrantenopsias. These are visual field deficits that are classically seen with glaucoma. And I'll just say here that this would be like your left visual fields. So this is nasal here and temporal on this side. All right. So the management for primary open-angle glaucoma is typically to decrease the intraocular pressure by at least 25%, but that goal will be set by the ophthalmologist. The medical management is with prostaglandin analogs and beta blockers. And there are other things that can be used, combination drugs that combine these two, alpha-2 agonists, but prostaglandin analogs and beta blockers tend to be your first line of therapy. So these prostaglandin analogs include latanoprost, bimatoprost, and trabecular, and then the topical beta blockers include timolol, ketorolac, levobuterol. Trying to think of some more. I think metoprolol. They have different names than the beta blockers you would give for blood pressure. So these are the two first lines of therapy, although it's up to the ophthalmologist. So you're not going to, if you think the patient has open-angle glaucoma, you're not going to do the treatment. You're not going to send the patient out on their way with prostaglandin analogs and beta blockers. You're going to send them off to an ophthalmologist, and the ophthalmologist will determine the treatment. And the ophthalmologist might opt to perform surgical treatment. Some of the surgical treatments now are very high-tech, laser treatments. The new one that's came out in the last 20 or so years is the argon laser trabeculoplasty. And that does exactly what it sounds. It fixes the trabecular meshwork to help drain the aqueous. All right. So secondary open-angle glaucoma, I don't want to talk about too much. This is essentially identical to primary open-angle glaucoma, but it's associated with an underlying cause. So trauma, uveitis, corticosteroids, etc. Some other notes. So normal tension glaucoma is considered a type of primary open-angle glaucoma because it's a glaucoma that develops in the setting of a normal angle. But the patient will have optic disc changes, and they will progress to other symptoms of glaucoma, and most importantly, the intraocular pressure is always normal. So a patient who looks like they have normal tension glaucoma and that they have optic disc changes, they have symptoms of glaucoma, but at some point their intraocular pressure is elevated and stays elevated persistently, then they're going to be diagnosed with open-angle glaucoma, primary open-angle glaucoma. Normal tension glaucoma, the intraocular pressure has to always be normal. And this is thought to be associated with vasospasm. So if the patient has a history of migraine headaches or Raynaud's syndrome, that's something worth eliciting. They tend to have a history of migraine headaches. If they have, particularly with visual auras, that's another important aspect too. If you do a fundal exam, you might be able to find small hemorrhages around the optic nerve head, and that's thought to be associated with vasospasm. If you do serial tonometry, and that's something you really should do to get yourself to the diagnosis of normal tension glaucoma, because a patient's IOP can change throughout the day. So it might not be the same in the morning as it is in the afternoon or in the evening. Serial tonometry, though, is always normal throughout the day, despite any symptoms that they may have. Nonetheless, even though their IOP is normal, we're going to use anti-glaucoma medications for these patients. So your prostaglandin analogs and beta blockers and alpha-2 agonists. Ocular hypertension is an elevated intraocular pressure in the absence of any symptoms associated with glaucoma and in the absence of any objective abnormalities. And that's important because remember, patients can have objective abnormalities like an elevated cup-disc ratio, but not have any symptoms of glaucoma. That's like what we see in the primary open-angle glaucoma. So it's very important that if you note an elevated intraocular pressure just on routine tonometry, that you rule out that there's no symptoms and there's no objective abnormality, including optic disc changes. Essentially, this is just an isolated elevated intraocular pressure. These patients do not need to be treated, but they need to be followed closely. Certainly, patient education is important. They need to be informed that they are at elevated risk for glaucoma. The higher their intraocular pressure is, the higher their risk is for developing glaucoma in the future. So you could have a patient with ocular hypertension that has 21 millimeters of mercury.